Thank you, Anne. Good morning, everyone. Thank you for the opportunity to talk today. I have no disclosures. And I'd like to acknowledge Dr. Anthony Zimmerman, consultant endocrinologist, and Jill Lyon-Green, nurse diabetes consultant, and also like to acknowledge that we're meeting on Kaurna land today and all the traditional owners. So we all know diabetes is important. It's the reason why we're here. And these figures are quite scary. Professor Young presented the worldwide figures, but these are Australian figures. So 280 people develop diabetes every day, and that means around 1.7 million, closer to 2 million people have diabetes at the moment. And this includes diagnosed and potentially undiagnosed type 2 diabetes. In the past year, more than 100,000 people have developed diabetes in Australia. And the cost is enormous. It's over $14 billion per year. So it's important. And the aim of all our glucose-lowering therapies are, of course, to prevent micro and macrovascular complications. And this has been well shown in large trials like the DCCT and the UK PDS trial. To achieve this, we aim for HbA1c targets under 7% for most people. And the way we do this is to aim for reducing postprandial hypoglycemia, also nocturnal hypoglycemia, and of course increase time in the ideal or target glucose range. And with this in mind, we'd also like to reduce hypoglycemia because it's often a trade-off of improving glycemic control. So patients that are treated with intensive insulin, such as multiple daily injections or continuous subcutaneous infusion pumps, will have to monitor their blood glucose at least 3 times a day for optimal glycemic control. So, and there's a few ways we can describe glycemic control. One is the quality of control, and that's using capillary blood glucose sampling, or we can use interstitial glucose as a surrogate, and that includes CGM and flash glucose monitoring. And these are 2 of the topics I'd like to focus on today as part of advances in diabetes management. We can also assess the quantity of control, and that's what we do when we use the HbA1c, which reflects the plasma glucose average over the preceding 3 months. We can also use fructosamine less commonly if there's a problem with the lifespan of red blood cells that affects the accuracy of the HbA1c. Urine testing is no longer recommended, unlike the poor gentleman in the figure who had to do it back in the day. So self-blood glucose monitoring, the aims are to allow identification of high sugars and low blood sugars, and also to provide immediate information to the patient about adjusting their diet, lifestyle, and medications. It assists them to achieve a better understanding of their diabetes and also improves adherence to treatment if they know what effect the treatment is having on them. And it can provide a motivational tool and improve quality of care. So ideally we'd allow improved glycemic control while minimizing hypoglycemia. So the American Diabetes Association and the Australian both recommend using multiple readings of blood glucose. And you can see that if you were to do it at all these times, it would take up a lot of your day, not to mention the painful finger pricks. So, and that's for people on intensive insulin. People who are not on intensive insulin may also be advised to check their blood glucose, especially if they are on hypoglycemia-causing oral medications such as sulfonylureas, or if their glycemic control is changing. So when we prescribe self-glucose monitoring, when we advise patients to check their glucose, we must also instruct them on what to do with that information. It's no use checking a blood sugar if you don't know what to do with it, and that's the importance of getting them to see the diabetes educator and knowing what to do with their blood glucose readings. So the blood glucose targets that we use, it depends what reference you read and whether you are pregnant or non-pregnant, but the guidelines are roughly between 4 and 7 for fasting and 4 and 10 for postprandial, and between 7 and 10 for inpatients. And it's quite difficult to achieve these targets. And this just illustrates that finger pricks don't always reflect what's going on with the glucose for most of the day. So the purple dots represent individual finger prick measurements, but you can see that if you just relied on those 4 measurements, in this example, you would miss the morning hypoglycemia and the postprandial hypoglycemia and wouldn't have a full picture of what the blood glucose is doing. And also relying on the HbA1c, which is a good measure of your average glucose, doesn't actually tell you how smooth your readings are around that average. So a HbA1c of 7.8 in the top diagram is not equivalent to the 7.8 in the lower diagram, because that average is obtained in the lower diagram by a lot of hypoglycemia and a lot of hyperglycemia. So continuous glucose monitoring has allowed us to advance in this field, and it has been shown now in conjunction with intensive insulin to lower HbA1cs in adults with type 1 diabetes. With increasing frequency of sensor use, you get lower HbA1c readings without increasing hypoglycemia. So this is particularly useful in patients with hypoglycemic unawareness, and especially in children or patients who are having a frequent nocturnal hypoglycemia. So how does continuous glucose monitoring work? You have a transmitter which sits on top of the skin and a cannula which sits underneath the skin. And with enzymatic technology, the sensor interacts with the glucose molecules under the skin to give a readout using an algorithm of a plasma glucose. So it approximates the blood glucose. It's not quite the same as the blood glucose. Oops, sorry. So this is an example of a continuous glucose monitor download, and you can see how much information we have. This is just one page of it. So you've got your time scale across the top from midnight to the next midnight, and then you've got your different time slots. So you've got your overnight and your breakfast, lunch and dinner time slots. And these are the days of the week superimposed for a 7-day period. So you can see that also in each time period, how much proportion of time is spent in the target glucose range, which is the white, or in hyperglycemia. So in this patient's case, the blood glucose levels overnight are quite good, but then you do have a lot of hyperglycemia for the rest of the day, especially postprandially. And that's a lot more information than we can get just from 3 or 4 finger pricks a day. Another page which gives a average estimated glucose as well as an estimated A1C over the 7-week period, and how much of the time they're spending in the target range and in the hyper and hypoglycemia range, as well as what to do with the different patterns that are detected. So it does give you a little bit of guideline, I guess, to know what to do next. And then you can see with each time slot the average blood glucose for each day. So it's a lot of information, and it can be quite overwhelming for people, but we do use this to make decisions with adjusting insulin dose. And then you can see each day by day and how it all superimposes with finger prick readings, and also the time of food and time of insulin, time of exercise. All that information is there for us to have a look at and make treatment decisions. And a lot of people find this very, very helpful. I know I do in practice. But what's really exciting is that you can have now continuous glucose sensors that use the current blood glucose as well as the rate of change of glucose, and also give you a prediction of how soon you are going to hit hypoglycemia. So you can set your alarm for an hour before or 10 minutes before you are predicted to hit a low. So this is quite exciting. And what's also exciting is that it can talk to other devices, such as your mobile phone or your iPad or your mum's laptop if you're a kid, and it can alert those people, even your care provider, your diabetes educator, or your endocrinologist about impending hypoglycemia. That could potentially be a little bit too much information, but it is quite useful. So the benefits are that you can identify trends in blood glucose patterns. You also, of course, reduce the painful finger pricks. It assists you in decision making, and it provides the practitioners with a very rich data set. We can tailor their insulin bolus types for the pump patients. We can tailor the basal rates, and we just have a much better idea of how to do that compared to just having 2 or 3 or 4 blood sugar readings a day. It does have some downsides though. It still requires daily calibration with finger pricks. Some people don't like being attached to something 24/7. There's sometimes tape allergies and problems with the sensor sticking for the whole period. And also, it really does require the patient to engage with the technology. So a lot of people aren't comfortable with that, or they just get alarm fatigue or overwhelmed by the sheer amount of data. Also, sometimes people didn't realise how bad their glycemic control was just by doing 3 or 4 blood sugar readings a day. So when you suddenly see all that data, it can be quite overwhelming. So while it is very, very good, it's also very costly. A lot of people can't afford it. It's over $1,000 for a transducer, and the sensors cost about $70 a week. However, there is NDSS funding for people under 21 in the 4-year trial, which is ongoing, which has been quite a lifesaver for a lot of parents and children. So I hope this continues. So choosing a device, we take into account the patient's age, their finances, of course, whether they're on a pump, because different devices can speak to different pumps or are compatible with different pumps, and also what mobile phone they have sometimes, because some of them don't talk to Android phones and things like that. But this is something the diabetes educator is very good at. So just slightly different technology. The flash glucose monitoring, which is an alternative, I suppose, to continuous glucose monitor. And this is a factory calibrated on-body device that you wear for 14 days. And it's composed of a sensor and a reader. The reader is scanned to the sensor, so you get on-demand blood glucose readings, well, interstitial glucose readings reflecting blood glucose readings. And the other good thing about it is you get trend arrows and predictions. So the one that's currently available, not that I'm selling any of them, but the Freestyle Libre is the sensor that's currently on the market. And it comes with an inserter and a sensor pack, and that's the actual sensor. So the sensor is quite small. It usually sits on the upper arm, and it stays there for about 14 days. And it's quite easy to apply. I've done it. It's not too hard. So, and the reader actually gives you a trend graph as well as the current blood glucose and an arrow that indicates the rate of change of the glucose, which I think is one of the most useful things about it. So the steepness of the arrow indicates how quickly the glucose is rising or falling based on what's been happening up to that point and its predicted rate of change. So this is very, very helpful, and most patients tell you that this is the most useful thing about this device. And it does store 90 days of data, and we can download it and we can see all the graphs just like we can for the continuous glucose monitors. So again, we get a lot of information from these reports. I haven't put one up there because it's really quite overwhelming, but it gives you the average glucose, the trends, even a monthly and weekly summary or day-by-day log if you want to go into it in detail. And we can adjust the target glucose. It also works as a normal blood glucose meter as well, because we always suggest that patients don't rely on the interstitial glucose, especially if they're feeling unwell or the glucose is changing very rapidly. They must always check with a finger prick. But it does reduce the amount of finger pricks. And I've got some data which I stole from the rep, But basically, they had this impact study that evaluated the effectiveness of the Freestyle Libre in reducing hypoglycemia. That was their primary outcome. And basically, it was a 6-month randomized controlled trial where they recruited really patients with very well-controlled type 1 diabetes, HbA1c less than 7.5%, who were already checking their blood sugars 5 times a day at least. So they were very well-motivated patients. They were all adults across 23 European sites, and they'd had diabetes for 5 years or more. And they had a run-in period where everyone wore the sensor masked, so they couldn't see the readings, and then they randomized 1-to-1 to continuing finger pricks compared to using the Freestyle Libre interstitial glucose readings. And then at 6 months, they compared the difference in time that they spent in hypoglycemia. That was the primary outcome. But they looked at some secondary endpoints, which I'll just quickly go through. So the patients, on average, had had diabetes for around 22 years, and they were already checking their sugars about 5.5 times a day on average. 2/3 of them were using multiple daily injections, and 1/3 were using pump therapy, and their HbA1c was 6.7% at study entry. The primary endpoint, they showed 38% reduction in time spent in hypoglycemia, which is, I think, quite clinically significant. And also in time spent in severe hypoglycemia, so blood glucose less than 2.5 millimoles per litre, and 40% reduction in nocturnal hypoglycemia. Without a change in HbA1c. So even though they spent less time having low blood sugars, their HbA1c didn't increase over this 6-month period. And it was only when the sensor wear became unmasked that they could actually see their blood glucose readings and do something about it, that the time in hypoglycemia actually changed. And that makes sense, I suppose, when you're actually using the information. It also reduced the time in hyperglycemia, which is interesting, and increased the time in range as well by 1 hour per day, which I think is quite significant. Also, patients really liked wearing it. They liked doing less finger pricks, and they were likely to recommend it to other people with diabetes. So that's quite, I guess, a good selling point. Not that I'm selling it, but and there were a few adverse events. There were only 6 subjects that withdrew due to device-related adverse events, and they judged these as being mild to moderate in severity, and all self-resolved without treatment. And they concluded that patients who already had well-controlled type 1 diabetes, who were already really motivated to check their blood sugars, had a reduction in time spent in hypoglycemia using this technology, and also improved time in range and reduced glucose variability. And it also, even for those people, increased their readings from 5 to 15 times a day. I know if I had had one, I probably would check it all the time just to see what's happening. So, yeah, I think this is all promising, and there's ongoing data looking at using it in pregnant women and inpatients and things like that. So watch this space. Now, insulin delivery devices, so just moving on to insulin pumps. They've been around for a while, but they don't look like this anymore. And even don't look like this now either. They're getting smaller and smaller. So the advantages are that they deliver more physiological insulin, and also can titrate the insulin to meal times, and have been shown to reduce hypoglycemia and improve glycemic control and improve quality of life. There's now trials looking at continuous glucose monitors together with insulin pump or CSII therapy, and this ASPIRE trial looked at sensor-augmented pump therapy, so using the sensor to tell the pump when there's a low glucose coming, and then to suspend the insulin before you reach that point. So this trial looked at using this over 3 months, and it did reduce nocturnal hypoglycemia without increasing HbA1c. And now you even suspend before low. So this graph shows the sensor glucose, and you can see the low limit has been set at 3.4 millimoles per litre, and the algorithm calculates when you're 3.9 millimoles per litre above that limit and stops insulin at that point, if it calculates that you will approach your low limit within half an hour. So upon stopping insulin, it then resumes it when the glucose is trending upwards and when the insulin has been off for at least half an hour and up to a maximum of 2 hours. And this has been trialled in paediatric patients whose parents were instructed not to treat impending hypoglycemia and just let the pump do the work, or let the algorithm do the work, and they showed a reduction in hypoglycemia and not increasing the mean glucose concentration. So these patients didn't over-treat their hypoglycemia because they had less hypoglycemia, because the insulin delivery was suspended before they even got to the hypoglycemia. And now there's also closed loop. So that is where the pump just stops insulin delivery. That was the previous one. Now it's where the artificial pancreas, where the glucose sensor actually tells the pump how to increase and decrease the insulin delivery. And it tries to approximate even closer physiological insulin delivery. And this pump, which is currently available in the US, is the 670G Medtronic, and it's coming to Australia as well. There's lots of others under construction. So the evidence so far, I've just tried to summarise. There have been a couple of studies in patients with type 1 diabetes, which have shown that it's safe and feasible and reduce the risk of hypoglycemia, especially nocturnal hypoglycemia. There was a study in type 2 diabetes in patients, which also showed that compared to basal bolus and finger prick monitoring, it also increased the time spent in glucose range in that setting, but they were quite small studies. And then there was a very small study in pregnant women, which showed, this is compared to a pump and sensor-augmented pump therapy. So this is just closing the loop. It had even better outcomes, so reduced hypoglycemia and increased time spent in target glucose range without increasing the total insulin, because you could think that it might require more insulin, but in fact it didn't. So, and there was a recent study that added pediatric data to that, and the top line shows the HbA1c in, so we've got children, adolescents and adults, and the top line shows the HbA1c at study entry and then 3 months later. And all the groups had a significant reduction in HbA1c by using the closed loop system, and also an increase in time spent in target glucose range, which was significant in all groups, but potentially more so in adults. So future directions, it's getting better and better. People are working on it. There's going to be less calibration, longer lasting sensors, because currently the sensors only last for 1 to 2 weeks. It will be more visible, I guess. There will be more accessibility for us providers, which could be a good or a bad thing, depending on how much we want to be constantly looking at people's blood glucose when we're not at work. And insulin pumps are also advancing very rapidly, some of them even now being developed with glucagon being included. So it's all very exciting. Now, just quickly moving on to medications. So just to recap, treatment targets are not the same for everyone, and the importance of targeting a HbA1c of 7 changes with different comorbidities and age of the person and all the other factors. So the longer you've had diabetes, the more comorbidities, and the older you are, the less that controlling HbA1c below 7 will be beneficial. In fact, studies show that it can be harmful if we target a HbA1c of less than 7 in people with already established cardiovascular disease. So targets have been suggested as higher, between 7 and 8.5 for people who are frail, elderly, or who have other comorbidities, and targets are still less than 6.5 for people who are newly diagnosed or planning pregnancy. So Professor Young has already alluded to this, but pathophysiology of type 2 diabetes is very, very complex. And we know Ralph DeFronzo described an ominous octet of the 8 factors leading to hyperglycemia in diabetes. This slide has added an extra one, which is the amylin secretion, but we don't have the amylin mimetics in use in Australia, so I'll just not talk about that. But the other factors are all very important. So in type 2 diabetes, there's increased glucagon, increased appetite, decreased insulin, impaired incretin effect, which we've already heard about this morning. Carbohydrate absorption is affected, and increased rate of gastric emptying and increased insulin resistance, as well as increased hepatic glucose production, which is inappropriate in the setting of hyperglycemia. So the medications all target different parts of this pathophysiology, and I won't have time to address all of them, but this graph I thought quite nicely put them all into which box they actually affect. But I don't intend this as a revision of all the diabetes medications. I just wanted to focus on a few key points. So this is the RACGP general practice guidelines for treatment of type 2 diabetes, which has recently been updated. And for first line, as we know, is always diet and exercise and metformin. Now, this is okay for most people, but if they start off with a HbA1c of over 10%, that's not going to be enough to begin with. So then we would suggest moving to 2 or even 3 agents, even from the beginning. And this algorithm has changed quite a bit in the last few years. It used to be metformin followed by sulfonylurea followed by insulin, and that was it. There was acarbose as well, but and the TZDs have largely fallen out of fashion, except for some very specific circumstances. But what's really exciting is more around the SGLT2s and the glucagon-like peptide agonists, so I'll talk about that, which currently are still in the 3rd line management, but these are only guidelines, and I think the main point is that the therapy should be targeted to each person, and not everyone needs to follow this algorithm, and different people have different indications for medications. And I guess that's part of our job, is to tailor the medication to the individual and not just follow the algorithm. This is a very complicated table, but I'll just direct you to these guidelines, which are the American Diabetes Association guidelines for management of type 2 diabetes. And in their first 3 lines, they talk about metformin, SGLT2s, and GLP-1s, which for them have the most evidence of benefit, and they've put the rest to the bottom. Of course, insulin still has its use, and it's very important, especially in people whose blood glucose is not controlled with oral agents or even with non-insulin injectables, or if their HbA1c is over 10 at the beginning, you can consider insulin. So SGLT2 inhibitors are one of the more recent developments. They inhibit glucose uptake together with sodium in the proximal nephron, as well as in the gut, as has been shown. But through the renal mechanism, they result in glycosuria. They also reduce blood glucose, blood pressure, urate, and weight. So basically, there's good evidence now for empagliflozin, which has cardiovascular outcome data, as well as both EMPA and canagliflozin reduce diabetic kidney disease and progression of macroalbuminuria. They have side effects, the most common being the increased risk of genital infections, but also with the canagliflozin, there's been signal for increased risk of toe amputations and minor foot amputations. This hasn't been borne out with all the other SGLT2 inhibitors and is subject of ongoing surveillance. There's also this very real and increasing frequency of euglycemic diabetic ketoacidosis, so I'd just like to spend some time talking about that, because I think it's important for GPs and really all health professionals to be aware of this. Patients may not be aware of this themselves, and I think it just needs to be flagged to them when starting an SGLT2 inhibitor. So this was a paper that was recently published by an Adelaide group looking at a case series of patients with diabetic ketoacidosis from SGLT2 inhibitors, and this was a case series over 18 months. And there were 13 cases that presented to Adelaide hospitals, including one death. And looking at the literature, they also were able to project and estimate an adverse rate of 1.8 cases per 1,000 patient years. So this is the data from the literature reviews. There was a total of 82 case reports in the literature from the world. And you can see that most of them were older, but there was a range of 25 to 88 years. Most of them had type 2 diabetes, but there were quite a few with undiagnosed type 1 diabetes, and a few that were using it off-label for weight loss that were not previously known to be diabetic. Most of them were with dapagliflozin, but that might be, because it's used in more parts of the world, so it might be just that bias. People were taking it for an average of 11 weeks, but anywhere from 1 day to 76 weeks, and only 12 of them had been prescribed insulin prior. The precipitating factors were usually illness of some other sort, acute coronary syndromes or infections, or surgery. So that's the one where we potentially could prevent these cases if we're a bit more alert and educate patients about what to do with these agents prior to surgery. But sometimes they were in the setting of fasting for other reasons, or doing low carbohydrate diet and reducing their insulin doses, or also from self-ceasing insulin. And a lot of them were misdiagnosis of type 1, where if you had known about it, you might have been on the lookout for it. And one case actually got 2 SGLT2 inhibitors, which is a bit scary. So the proposed mechanisms, there's a few, but essentially through the renal mechanism, glycosuria is increased and ketone bodies are reabsorbed as well. And then there's increase in lipolysis, increased free fatty acids resulting in ketogenesis, as well as reduction in insulin from beta cells. And all this is a perfect setup for diabetic ketoacidosis, especially if the patient is fasting, has reduced carbohydrate metabolism, and also is unwell. So the key issues that came from this was that most patients didn't even know about it, a lot of practitioners didn't pick it up, and it was often a misdiagnosis. Patients treated in ICU for 5 days before anyone knew what was wrong with them. One case was unfortunately died, and 2 cases were off-label use. And then, of course, there's the issue of misdiagnosing the type of diabetes that they have. So the recommendations were that we stop the SGLT2s in preparation for surgery. We would recommend 2 to 3 days. And we educate patients and GPs and diabetes educators and everyone who's involved in diabetes care about ketone testing for patients who are on SGLT2 inhibitors. Of course, if they're unwell, we also tell them to hold it. We tell them to keep taking carbohydrate and keep taking their insulin if they're on it. We can use them in type 1 diabetes. There's some good emerging evidence for that, and certainly I've got a few patients who are on SGLT2 inhibitors with type 1 diabetes, and they've had good improvement in glycemic control and weight loss. However, this is with very good education and giving them a ketone meter and teaching them about how to test for ketones and what to do about it if they have ketones. And I think importantly we should make sure our colleagues are aware, because a lot of the time ED doctors didn't recognise this phenomenon. Now moving on to GLP-1 receptor analogues. So as this has been shown, increased glucose-dependent insulin secretion and suppress inappropriate glucagon secretion, which is quite high in type 2 diabetes. They delay gastric emptying, and that's one mechanism by which they slow glucose absorption and decrease appetite. They can have side effects of nausea and vomiting, but we can educate patients about this and teach them how to manage it, quite similar to pregnancy-associated nausea and vomiting, and not with using antiemetics, which will counteract this mechanism. Weight loss is a good effect of these medications, and there's a question mark about increased risk of pancreatitis and potentially pancreatic cancer from post-marketing surveillance. There's nothing definite, but we must keep an open mind and perhaps not use them in patients who have had pancreatitis, especially recurrent pancreatitis. And the DPP-4 inhibitors, similar mechanism. So you've got your incretins from the gut, your GLP-1, and the DPP-4 is an enzyme that breaks down GLP-1. So DPP-4 inhibitors inhibit this enzyme, so allowing GLP-1 to function in its normal state. They don't have quite as good a glycemic effect as the GLP-1 agonists, and they have neutral weight loss effect. They also don't have the cardiovascular outcome data, which I'll just mention now. So empagliflozin, the SGLT2 inhibitor, which I mentioned initially, had the first cardiovascular outcome trial that showed positive cardiovascular effects. So it reduced the composite cardiovascular outcome of MI, stroke, and cardiovascular death by 14%, but actually the main driver was the reduction in cardiovascular mortality, which was 38%, which is really quite impressive. Then they followed with the GLP-1 trial, which was the leader trial, which showed that liraglutide reduced the composite cardiovascular outcome by 13%, quite similar. DPP-4s have had cardiovascular outcome trial, which show that they're non-inferior to placebo, so they don't cause increased cardiovascular risk, except potentially for this increased heart failure hospitalizations, but they didn't have an increase in the primary endpoint. And so far the evidence is quite neutral for the DPP-4s, but there's new data coming, so we need to keep an open mind. And I thought this was just nice to put it in perspective as to how many patients you need to treat to prevent one cardiovascular death. So the statins, which have had a huge impact in patients with diabetes, reducing cardiovascular risk. In the 4S trial, you needed to treat 30 patients with simvastatin for 5.4 years to prevent one death, and this was before the statin era. After that, people started getting put on statins. In the trial looking at ramipril, the HOPE study, looking at ramipril for blood pressure, you needed to treat 56 patients to prevent one cardiovascular death. However, not many patients were on statins during that study. For the empagliflozin, the EMPA-REG study, you needed to treat 39 patients to prevent one death, and that was over 3 years. But noting that 80% of patients were already on ACE inhibitors or ARBs, and more than 75% were already on statin. So this is in addition to statin and ACE. And the leader trial, the liraglutide, same patients at high cardiovascular risk, already on all these medications, and you needed to treat more to get the one benefit. So I guess for the medication side of things, the take-home messages for the microvascular disease, we still need to control the glycemia, but HbA1c isn't the be-all and end-all. And we need to individualize targets based on patients' either comorbidities, age, and duration of diabetes. For the macrovascular disease, the cardiovascular outcome trials suggest that we need to use the evidence that we have, and at the moment that evidence is mainly for empagliflozin and liraglutide. And this is for patients who have had cardiovascular disease or have multiple risk factors making them high risk for cardiovascular disease. Metformin diet and exercise is still important, and we must never forget about that in the first instance. And in fact, I didn't mention, but metformin also has cardiovascular data that is much older than the EMPA-REG trial that is positive. And I just wanted to raise people's awareness about the euglycemic ketoacidosis with SGLT2 inhibitors. And these are my references. Thank you.